Welcome to the conference session titled Survivorship, Life After Diagnosis. Thank you for joining us. My name is Nyari Sireu, Patient and Professional Program Coordinator, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, that you submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Rachel Schmid. Rachel is a nurse practitioner who earned her MSN in 2015 from Clarkson College and her DNP in 2019 from UNMC College of Nursing. Rachel runs both the Survivorship and the Cancer Risk and Prevention programs at Nebraska Medicine. When she's not in the clinic, Rachel works to develop research protocols and recruiting trials to come to Nebraska Medicine. With that said, welcome, Rachel.
Thank you. So, like we talked about, I'm going to be talking about survivorship, life after cancer, which is a very big topic, so bear with me. So when we talk about this, I always like to bring up that there is a National Cancer Survivors Day. This is the first Sunday in June, and we'll talk about that in a little bit, but I do like to recognize that up front because it is very important when it comes to the care of cancer survivors. So whenever I talk about cancer survivorship, everyone kind of hates the word survivor. There's a little bit of the survivor guilt. People don't think I've had enough treatment or I've had enough side effects to be a survivor, or they don't want to be called that because they don't technically know when they became a survivor. So we're going to dive into this definition right now. So who is a cancer survivor? It's technically, by definition from the NCI, anybody who's been diagnosed with cancer. And that includes everyone living with cancer, anybody that's living through cancer, so actively going through treatment, and beyond. So technically the definition starts at diagnosis through the rest of your life. And this is just a picture of me and my mom. My mom is a cancer survivor as well. So I always like to include this because it is personal for everyone. So when we look at cancer survivorship, this is a graph. If anybody's ever seen me present or a cancer survivorship presentation in the past, I'm sure they've seen this graph on the left. It just looks at the population of cancer survivors in the US. We really didn't see or keep track of cancer survivorship until the 1970s, where you can see that we started out at 3 million. And if you look to what we are to date, we are right around 17 million, and we are projected to be over 26 million by 2040. So this is all attributed to earlier diagnosis, better treatments, better screening, all of those types of things that help us. And then if you look at the age breakdowns, that's what the colored graphs are. We know that the majority of patients who are surviving a cancer diagnosis are over 65. So this is really important as we look at cancer survivorship research as well. And the graph on the right looks at survivorship grants and funding, and as you can tell, we didn't start doing any type of survivorship research till the early 2000s. So all of the data that's coming is very new, and we keep learning more and more, and it gets updated because cancer survivors are living much longer. So what do we know about cancer survivors? This is very broad. We're going to talk about this for the next 45 minutes. But We know that most cancers have a decreased risk of recurrence at least, or once we get to 5 years out of diagnosis. And this creates a shift of focusing on late and long-term effects and surveillance rather than focusing on the current or their risk of recurrence. And then therapy-related complications increase morbidity and mortality, and there's a lot of other things that we have to factor in when it comes to that, like heart disease. And then early detection through screening and risk reduction helps lessen some of the late and long-term effects, which we're going to focus on a lot today. So, big survivorship challenges. There was a huge report that came out in 2006. Anybody that Google's cancer survivorship will probably find something related to the Institute of Medicine report called Lost in Transition. This was the major report that came out that kind of put survivorship on the map, and what helped transform some of the accreditation guidelines within the Commission on Cancer, which is a big accreditation for NCI cancer centers. And so some of the major things that came out of that is cancer survivors told everyone that they felt lost in transition. They didn't know what to expect once they finished their treatment, because we know that during treatment, everything is very regimented. You're coming in weekly or every couple weeks. You have a very regular schedule. Everyone makes your appointments. You're coming in for chemo or radiation, surgery, whatever that is, and you just show up. But then once treatment ends, we don't know or patients said that they don't know what to expect. How often are they supposed to come in? When are they supposed to see certain specialists? So that was the major thing that came out of this report. They also found that there was a lack of communication between between primary care providers and the oncologists, as well as the oncologist and the patient. So communication became a huge component of survivorship care. And then patients also weren't aware that there was long-term risks or health risks after they finished cancer treatment. They thought that they were done, they were going to go back and live their life, but there was new things because they had cancer treatment that they had to look out for, and they were not aware of that going into cancer treatment. And lastly, patients reported that they had more or higher difficulty restarting work or school after cancer diagnosis, and that was just pointed out as another transition issue within this report. So one of the major things that came out of the Institute of Medicine's Lost in Transition report was a recommendation that every patient should receive a survivorship care plan. This is like my one that I use for every presentation. I see a lot of adult survivors of childhood cancer. And so as you can see, this patient was diagnosed when they were 16. We outline their treatment, so if they had any surgery, what chemotherapy they had, and if they had any radiation. Also, if this patient had a bone marrow transplant, we would include that. But this prompted this initiative that all patients who get cancer treatment should receive this type of document, and it should also go to their primary care provider as well. The reason behind this is, and I try to tell all my patients as well as oncologists that I work with, surgeons, radiation oncologists, is that when we get admitted to the hospital for any type of surgery or illness, we get sent, or our primary care provider gets sent a discharge summary. And this is what I like to compare it to. This can be called a discharge summary after cancer treatment. So to summarize what a survivorship care plan is, it outlines all of the treatment, any potential late and long-term effects moving forward, and then what that schedule of follow-up would be. And on here, let me see, is another example of the next sections on a survivorship care plan. At Nebraska Medicine, this is what our care plans look like. At other institutions, they can look very different, but this is just how we've outlined them. So we like to have how often they'll be coming in for routine scans, because a lot of patients think that they might need, a CT scan every 6 months, where the guidelines might change and we need to update them on that. And inform them that it's only if they're having signs or symptoms, or how often they need to come in for labs. Who is responsible for that? Is it the primary care provider or is it the medical oncologist? If they need any additional screenings, such as echocardiograms or breast MRIs because of the treatment that they've received. And we will talk about that a little bit in the next couple slides. So this also shows, based on your type of treatment, what late and long-term effects to be aware of. It doesn't mean that you're going to get any of these, but we just want to tell you that there is a small chance, because you've had certain types of chemotherapy, you may be at higher risk of secondary cancers such as leukemia or additional solid tumors. Cataracts are very common, pulmonary issues, peripheral neuropathy, liver toxicities, fertility issues moving forward, sexual health issues, and then radiation can have its own specific side effects depending on where you were radiated in your body. So we outline that based on exact area of treatment. So the last page of this is the recommended evaluation. So we explain exactly why we would recommend these things. So we would recommend to monitor for a secondary leukemia because of chemotherapy that you've had in the past. We want to get a yearly CBC or complete blood count every year moving forward for the rest of your life, just to watch for that very low risk of leukemia because of chemo in the past. This patient, she was very young when she was diagnosed, so when she had radiation to her chest, we do breast MRIs and mammograms much earlier because there is a higher risk of breast cancer in these patients, as well as doing an echocardiogram earlier because of chemotherapy and radiation of the chest. So this is just a specific case, but again, if you ask for a survivorship care plan, they should be able to outline these things specifically for you. So instead of going over that fictional person, we're going to talk about surveillance and survivorship, and maybe you can take some of these hints moving forward of what to expect or what to look for. I like to talk about late effects and long-term effects. They're a little bit different, so I do have the separate definitions up here for you. But long-term effects are anything that can happen during treatment. So while you're getting chemotherapy, some patients may develop chemotherapy-induced peripheral neuropathy, the numbness and tingling in their hands or feet. That happened during chemo. It doesn't generally happen after it, but it can stay for a long period of time, if not the rest of your life, depending on your body. And then late effects are things that do not happen during treatment, but may happen 5, 10, 20 years down the road. So these are things that we need to be actively screening for moving forward. And an example of this is cardiac toxicities because of treatment that you may have received. So first thing that we're going to talk about are second cancers, and this face may be very familiar to everyone, but this is Robin Roberts, and she is very well known. I don't know, hopefully you guys know of her history, but she had breast cancer at triple negative. She was treated with chemotherapy, and then years down the road, she ended up developing MDS and having a transplant. So we call this a second cancer. Because it happened at least 2 months after their initial cancer. And cancer survivors actually have a slightly higher risk of developing a second cancer for multiple reasons. It could be because of environmental exposures, sometimes sun, tobacco use, alcohol use, lifestyle, genetic factors such as a genetic variant like a BRCA mutation, Lynch syndrome, or because of the specific cancer treatment that you've received, whether that's chemo, radiation, surgery, etc., or transplant. So screening for second cancers, again, is completely dependent on what type of cancer treatment you've had, but these are some of the things that we may recommend moving forward, like a yearly CBC, to screen for leukemias, or a yearly low-dose chest CT if you had a history of smoking. That is a way to screen for early lung cancer. If patients had total body irradiation and they're younger, we're starting to screen earlier in patients, at least by 45, but they just changed the guidelines, so this is my fault. It's technically 30 now. And then if you've had any radiation on your body, we are recommending a yearly skin exam by a dermatologist. Women, we want to make sure that everyone's up to date on mammograms and screening breast cancer at age 40. If they've had chest radiation, we'll do that much earlier, as well as prostate cancer for men. So the next and most common symptom, or late and long-term effect technically, would be fatigue. So I would say, and I agree with this slide, at least 90% of my patients have cancer-related fatigue at some point during their treatment, and about 30% state that it can last years after treatment. I might be a broken record today and say a lot of the things that can help with fatigue relate to exercise, and I know that I have patients tell me all the time, Rachel, you are a crazy person for expecting me to exercise when I just told you I'm tired. But all the research points to exercise helping break that cycle of fatigue. So even if you can just walk more and sit less, that's a good start. And then we try to put together a stepwise fashion of how to increase that exercise. But there are a lot of other things that can cause fatigue, and in our survivorship clinic, we like to screen for everything that could be contributing, whether it's depression, hypothyroidism, sleep apnea. We try to rule out everything, including low testosterone in males. So psychosocial challenges that are common are anxiety. I would say around 100% of my patients have some type of anxiety, whether it's related to fear of recurrence, just unknown uncertainty moving forward. Depression is very common, isolation, body image changes. A lot of patients in our bone marrow transplant world have issues with losing a lot of weight after transplant, and they just feel like they're not themselves because they've lost all their body mass. So those are things that we talk about and we screen for every visit that we have in survivorship. And then cognitive impairment, this one used to be called chemo brain. We really try to use the term brain fog now because we know that patients who don't get chemo also can have some cognitive impairment as well. But it's estimated as high as 75% of patients can have cognitive impairment, and it's very common. The biggest thing in the research is acknowledging it and trying to do brain stimulating exercises like Sudoku or crossword puzzles or Wordle, whatever you want to do. Again, exercise is encouraged for this side effect as well. We can do some neuropsych testing if symptoms are really bad. We do a lot of other type of cognitive testing, like using the BLESS test, which just tells us if symptoms are moderate, severe, or normal. But again, we have lots of things. There's no medications right now that are shown to really help with this, though. Oh, and it does get better. I will say in all the research, they say at least 2 to 3 years it will improve, or it should improve. But then again, if it doesn't, we need to look at other contributing factors like age that can, everyone can have some cognitive impairment as we get older. So chemotherapy-induced peripheral neuropathy, this is the numbness and tingling that some patients might describe. Others might say that there's pain or temperature sensitivity. I had some patients say that they might have like electric shock feeling, but about 1/3 of patients will develop this with being exposed to certain chemotherapies. And it can be reversible. It can get better the longer that you are out from chemotherapy, but some patients may have it for the rest of their life, and it definitely affects quality of life. Again, exercise can help with this, and I'm so sorry for saying this, but I just want everyone to realize that exercise can help with a lot of cancer symptoms. But things that we need to be aware of when it comes to peripheral neuropathy is when you have this, is there any fall risk in your house? We don't want you to trip on rugs because some patients can't feel around their feet. We want them to be careful cooking because they can't feel the temperature changes on the stove. We don't want them to, burn themselves in the shower or things like that. So just removing anything that can contribute to falls is very important. So sexual function is another side effect that we evaluate, and in the research you can see that there's a huge range of patients that report symptoms regarding this, anywhere from 40 to 100% of patients. And this can be anything from vaginal dryness, pain with intercourse, erectile dysfunction, you name it, hot flashes. So it is a very wide or broad topic. But we do know within the research that we need to ask about it. Not everyone feels comfortable talking about it. And if we don't feel comfortable talking about it, then the patients won't. So it's definitely something that we need to bring up. But if everyone on this call, if you guys feel like there's something that is bothering you, please bring it up to your doctors if you feel comfortable. Otherwise, find somebody that you do feel comfortable talking to. There's a lot of treatments out there that we can discuss, but I didn't list everything because it just depends on what is happening. Osteopenia and osteoporosis are incredibly common. So osteopenia is a precursor, so it goes normal bone density, osteopenia is the next step, and then osteoporosis is when we know that you have a high risk of breaking or fracturing your bones. So in our patients, we know that there's lots of different treatments out there that can contribute to bone loss, and so we want to make sure that we are educating our patients to help prevent this as much as possible or protect our bones. So having adequate calcium and vitamin D is important. Most patients in the Midwest are actually vitamin D deficient when we check them, and so we do recommend vitamin D3, 2,000 IUs per day at minimum. If you're very low or, under 30, then we might do a high dose supplementation for 3 months, and then in addition to the 2,000 units a day. We would recommend a DEXA scan, and all women are at high risk anyways, and we check them somewhere between the ages of 60 to 65, but in any patient who has been exposed to cancer treatment, we check them much earlier. So a DEXA scan looks at the thickness of your bones. We really look at the femoral neck, because when we fall, we typically land on that area or on your hip. And we do not want our cancer patients breaking a hip on top of everything else. So we will screen to see where your bones stand, if they're normal, osteopenia, or osteoporosis, and then we really encourage lifestyle factors such as weight-bearing exercises. If you smoke, please stop, as well as limiting alcohol use, because those can all contribute to weakening your bones more. As for calcium supplementation, I usually tell patients that we recommend getting calcium through diet. So milk, cheese, yogurt, or green leafy vegetables all have plenty of calcium, and as long as you're getting 2 or 3 servings of those per day, you're getting plenty, and you don't need to give you additional calcium. Unless we know that you have osteopenia or osteoporosis, then we might recommend additional. So cardiovascular toxicity, this is heart disease or heart complications after cancer treatment. We actually have a new phase or a new consulting service called cardio oncology, and this team looks at preventing or treating patients with cancer who face heart problems. And so we want to help prevent patients that have heart problems up front and they're getting cancer treatment, we want to make sure that they are able to continue getting cancer treatment. For patients that had cancer treatment and then develop heart problems, we want to make sure that we manage that and prevent it from worsening. So this team really helps us with that. It can be anything from high blood pressure, high cholesterol, up to heart failure. And so we may do what are called echocardiograms, which are ultrasound of your heart to look at your ejection fraction and make sure that your heart is pumping as efficiently as possible. But biggest things that we can do, as all humans here would benefit from, is just watching blood pressure, watching your cholesterol, managing any risks for diabetes, making sure our weight is optimal, exercising again, and then not smoking. But we do know, and I will talk about it in a little bit, that when compared to general population, cancer survivors are twice or 2 times higher risk of developing cardiac disease. So this is very important. And then pulmonary toxicity, this is any lung complications. So we do baseline pulmonary function tests to anyone who has received chest radiation or treated with the chemotherapy called bleomycin. And then we will repeat this in our bone marrow transplant patients for at least 3 years. And then anytime there's new shortness of breath that's developed. Endocrine issues, so we know that in the first 5 years for patients who have been treated with a transplant, they can have a higher risk of hypothyroidism. So if anybody notices that they're getting labs that are called TSH or free T4 being drawn, that's to screen for underactive thyroid. And so, or if you have new signs or symptoms of fatigue, sensitivity to cold, dry skin, weight gain, let us know and we can always check that earlier. But around 30 to 60% of patients will develop hypothyroidism. Fertility is a big thing that's getting a lot of attention in major cancer centers. We were not great about checking or asking patients about fertility preservation, 15, 20 years ago, and now we're implementing a lot of protocols up front that anybody who's under the age of 45 should be at least talked about the potential risk of infertility undergoing cancer treatment. So there's lots of chemotherapies that can cause fertility risk or infertility risk, and so with that, we just have these conversations with patients up front. If there's any, even if they're ambivalent about this, we just want them to be aware. But it's the best thing to do is preserve eggs or sperm preservation rather than talking about it after the fact, because there's not as much that we can do. And then, of course, social and financial issues are very common. So a lot of things, we work very closely with social work and some of these things, but when patients bring up that they are having issues with family or friends or trouble with health insurance or concerned about some of those things, we make sure to connect them with the social work team right away. So I did a lot of talking about side effects, and it is a huge part of what we do within our survivorship visits. I hope that everyone gets offered a survivorship visit, that we try to do that at Nebraska Medicine with all of our cancer patients, and we find it to be a standard of care because not all physicians or providers have time to go over everything that we talked about, let alone prevention or healthy lifestyle type things. So in our visits, we spend 1 hour with patients. We go over the entire treatment summary, late and long-term effects. We do those screenings. We make sure that everyone's up to date on health maintenance type issues, like do you have your mammogram? Were you a smoker? Do we need to do a low-dose CT? If you're under the age of 65, when was your last PAP? When was your last colonoscopy? But then we also talk about physical activity, diet, and other lifestyle issues such as sleep to see if there's anything that we can help educate on to lower future cancer risk. So we spend a lot of time on prevention, detection, and treatment of late and long-term effects. So this is our team at Nebraska Medicine. As I was introduced, I'm our program director, but I also see patients. Dr. Tenner, is our medical director for our solid tumor program, whereas Dr. Bott is our medical director for our transplant or our blood cancers. And then Molly and Amanda are my colleagues that also see patients with me. So at Nebraska Medicine in our survivorship program, we have had this since 2016, and we just keep growing year after year and adding other types of clinics on. But we do have a general clinic where we see any type of patient who has a history of cancer. We also have a long-term follow-up clinic for allogeneic stem cell transplant, as well as an adult survivors of childhood cancer clinic. Those two clinics, the long-term follow-up and then the adult survivors of childhood cancer clinic, we see patients yearly for the rest of their life to help screen for those late and long-term effects. So these are areas where survivorship should be inserted in the cancer continuum. We don't only need to be seen on the back end, but during diagnosis. I told you everyone's a cancer survivor starting at diagnosis, and sometimes you might see us right away. So those things would include for oncofertility or fertility preservation, contraception counseling, because we do not want patients to get pregnant during cancer treatment, as well as prehabilitation, which is something that we do with our transplant patients because we want them to be as healthy as possible or as functional as possible moving into transplant. And then during treatment, sometimes our doctors like us to see them to help manage side effects. And then after treatment is really when we start focusing on the treatment summary, the survivorship care plan, late effects, health promotion, because now we're kind of past that busy stage and trying to help refocus onto a healthier lifestyle and moving on to prevention. So these are all the screening questions that we ask our patients. This is why we have an hour-long visit. But we go through everything from heart disease, anxiety, depression, cognitive function, fatigue, lymphedema, pain, hormone-related symptoms, sexual health, sleep, immunizations, as well as lifestyle factors. And then for special groups, we will ask them about physical function, what's their balance like, are they able to get, what's their muscle mass like. We do the BLESS test, which is the cognitive testing, as well as deeper dives into sexual function if they ask or answer any questions positive to the initial one. And then the stop bang is more related to sleep apnea if there's any sleep issues that are going on. So when you think about survivorship, we have a huge group that we refer a lot to: nutrition, psychiatry, psychology, PT, OT, support groups, social work, smoking cessation, genetic testing, financial services, oncofertility, cardio-oncology, and then endocrine oncology. I would argue anybody that all of these groups are actually practicing survivorship. So we really want to help educate that survivorship is more than just a survivorship care plan. It's really focusing on improving quality of life moving forward for the rest of the patient's life. So all of these people are trying to do that. We see a lot of patients for genetic testing as well on the back end. Sometimes with our bone marrow transplant patients or our blood cancer patients, everything is done very quickly up front. And so when we learn about family history or things like that, then we have to do some of the testing on the back end or after treatment has ended. So genetic testing is very important then too, if there's significant family history. So another thing that I like to talk about is survivorship and lifestyle factors or lifestyle behaviors, because I told everyone a million times now that exercise is very important. But these are just some statistics that I always find a little bit surprising when I pull the data. But 17% of cancer survivors continue to smoke or are current tobacco users. Only 31% of 31% of cancer survivors are obese versus 28% in the general population, and only 38% state that they exercise. So we really want to try to transition patients into healthier lifestyles because we know that a lot of cancers, in the data it says over 50% of cancers can be prevented by lifestyle changes, including avoiding weight gain, eating healthier, drinking alcohol in moderation. The American Cancer Society, as well as the American Institute for Cancer Research, links many cancers to drinking alcohol and smoking. So if we can do anything to lower our risk for cancer, it's cutting those two out as much as possible. And then also making sure that everyone is being up to date on their other screening tests, because cancer survivors are less likely to get additional cancer screenings moving forward. So sun safety is important, and then vitamin D. We know that there's some newer data coming out saying that people who have vitamin D deficiency are at slightly higher risk for breast cancer, as well as colon cancers. So we just want to make sure everyone has is not vitamin D deficient. So a good graph, and anybody that wants to Google some websites out there, is the American Institute for Cancer Research, but they have great cancer prevention guidelines out there. All of their guidelines state that they can be used for cancer survivors as well, because we know that those can reduce the risk of recurrence or new cancers. So all the things that we've been talking about are on here. They have great blogs that talk about myths versus facts. There's lots of things, alkaline diets, soy, all of that stuff is included on their website. So if you have any questions, please go check it out. They also have a cancer health check questionnaire on there where you plug in how many fruits and vegetables you eat, what your weight is, how much you exercise, how much you drink, if you smoke, all of those types of things, and I'll tell you where you can, what you can do to help lower your risk for cancer moving forward. So the next thing that I'm going to talk about as we transition is how can survivorship help your care. We know that there's a pending crisis out there. There's a lot of cancer survivors, and there's only going to be more because we're getting better at treating, but we also have this older population, and so it's going to cause more cancer survivors in addition to clinician shortages in both primary care and oncology. So the other major issue with that is that primary care and oncology do not get regular training in survivorship. So this is all separate training that needs to happen. And oncology physicians, as well as primary care, do not have the time to talk about survivorship. As we talked about, there's a lot to talk about. And sometimes this is lower priority on everyone's list. So when we talk about how we can incorporate survivorship, we look at low, moderate, and high risk, and we really try to help with these higher and moderate risk patients when it comes to, supplementing your oncologist or primary care provider. And so that's why you may get a recommendation to see a survivorship provider. So we also want to help oncologists see more patients who are on treatment because those are the patients that are going through this and may need treatment changes or because of side effects or reactions and things like that. And other patients may need more time spent talking about fatigue, nutrition, exercise, fear of recurrence, and that's something that survivorship can help with. So if you ever hear that your visits are being replaced by a survivorship provider, that's a good thing. That means that you're not, you're doing well, and they want you to spend more time focusing on other things that can help reduce your risk for the future. Another thing that we help with is the health promotion, like we talked about with cardiovascular disease. We know that people are at very high risk. The majority of cancer survivors actually die of heart disease and not their cancer. So we want to help lower people's risk by watching their blood pressure, their cholesterol, screening them for diabetes, all of those types of things. And we know that cancer survivors actually have the same risk factors as most people with heart disease, being older than age 65, having at least one one or more comorbidities and increased weight. So we like to just make sure that we're screening everyone for that when they come in for survivorship. And then again, with the second cancers, at least 20% of cancer survivors will get a second cancer. So just making sure that we're screening for additional cancers and stressing the importance to get your mammogram, colonoscopies, low-dose CT if you used to smoke or still smoke, Pap screenings or PSAs for if you're female or male. And long-term cancer survivors are not more likely to receive follow-up screenings for second cancers, so we just want to try to improve that compliance moving forward. I actually have a lot of patients that have never had any cancer screenings until they were diagnosed with cancer, and then they still didn't want to until we started talking about some of these facts, and then we got them in for everything. And other cancer risk factors, like we talked about, the treatment-related issues for second cancers regarding being exposed to chemotherapy, radiation, or hormonal therapy, as well as all of the lifestyle things will determine what type of cancer screenings we'll do moving forward. So to kind of wrap up, I like to talk about an upcoming conference. It's Friday, June 9th. We have a survivorship conference every single year. It's really great. We focus on, well, this year we're focusing on epidemiology of cancer and cancer survivorship, as well as health risks with all of our specialists. So one of them is on heart health, bone health, lymphedema, and then body image, and then the role of a primary care provider, health disparities, and then we have a really great provider panel as well as a cooking demonstration. So it's a quick half day, but it's online and in person, so you can go ahead and sign up at nebraskamed.com/survivorship events. On our website, there's another way to get there. I don't know if I can. No. Okay, but in the top left corner, if you hit Cancer Survivorship Conference, that's another way to get there, but we also post all of our recordings from past conferences on here, so there is a library of information for any patients or providers that want more information about survivorship. And that is all that I have for you guys today. Oh, oops, I'll leave it here.
Thank you so much, Rachel, for coming
Yes.
out today and sharing your time and expertise with us. Do we have any questions in the room? If not, I will go ahead and ask a question as we wait for our online folks to ask a question. You spoke a lot about, conversations with people who've been diagnosed. And I was just wondering how you navigate, conversations about, forward-thinking things, like harvesting your eggs or sperm with someone who's just been newly diagnosed at a time when maybe cancer itself is still a shock. So how do you navigate those conversations, get them comfortable?
Yes, that's a great question. So oncofertility is a big deal, and in the research, they say that infertility diagnosis is just as difficult as a cancer diagnosis. So then when you have both of those, that's, very alarming, and a lot of people can have depression from that. So when we found that out, we've had a lot of different things that have been implemented to make sure that we don't miss patients moving forward. So when we talk to patients and they're very worried about, all the steps that come with cancer treatment, what they need to think about, we talk to them. If there's any chance that you want kids in the future, we need to have this conversation because you're going to think about this once you're through cancer treatment, and we don't want you to regret any decisions of not moving forward. There's a lot of barriers financially when we talk about this too, but with that, we have grants through Livestrong and many others that I'm blanking on right now, so I'm sorry, that we can offer patients. And then our reproductive endocrinologists are phenomenal about giving discounted rates to help offset any costs related to this, because we know that it's incredibly important. So we really talk about any potential risk, and if you have this conversation with us, It's hard to figure out exactly what it's going to be, but it could be anywhere from 0 to 33% chance, which is a wide range, or 30 to 70% chance. So if there's any risk, we highly encourage that instead of taking the chance, we really want to try with the fertility preservation.
Thank you so much for that response. We also have a question from online that says, if my disease relapses, am I still considered a survivor?
Yes. Yep. Living through cancer or with it is still considered a cancer survivor. The other question that I get all the time is from patients is, when am I cancer free? And I feel like that's a really hard question that nobody likes to answer. But if you ask your doctor, they probably won't ever give you a good response. But technically, we try to do everything in our power to get rid of your cancer. Once you have the bone marrow transplant, from that point on, we are trying to minimize your risk for recurrence. So those are what I usually tell patients when it comes to bone marrow transplant. If it's like a solid tumor that we're talking about, which in this scenario, it's typically not, but once your cancer is removed from the body, then you can use that as your cancer-free date. But I bet if you have like 3 doctors on your team, none of them will have the exact same date for you. So try not to focus on a date when it comes to being cancer-free.
Thank you. We also have a patient who says, it is hard to see myself as a survivor. Any suggestions on what I can do to improve my self-image?
So that you may have survivor guilt, or trying to, I don't know this person's scenario, whether they've had a lot of treatment, not enough, barely any treatment, but everyone is a survivor. I think working on coping skills and some of these things, it depends on what the person's going through when they mention that. But we try to journaling is really great, digital storytelling, talking about what your experience was. I think all of those types of things can help pull out your story and realize, oh, I have been through a lot and I am a survivor. I hope that makes sense.
Yes, thank you. Could you also speak a little bit about why cancer survival rates often use the 5-year survival rate? What is it about the 5-year mark?
That's a good question, and I feel like since I'm not a medical oncologist, I probably am not the best person to answer because I'm not deep into the data with that. As a nurse practitioner, we just always hear about the 5-year survival rates. In my solid tumor world, we just know that after 5 years, the rates decrease significantly. I'm just going to leave it at that. I'm sorry.
Good. Thank you. I think my final question today says, I am not treated at Nebraska Medicine, but do all cancer centers have a survivorship program? How do I find one?
That's a good question. So not all cancer centers have a survivorship program. We at Nebraska Medicine will see anybody, no matter where they were treated. We have a lot of patients that come from all over the country. We do telehealth visits, but that's it depends on where you are if we can actually do that or not. So I'm sorry for saying that. How you can find one is if you're on your cancer center's website, you can always just search survivorship. Otherwise, there are NCI cancer centers generally have a survivorship program. So I would search that way too.
Right. Thank you so much, Rachel, for coming out today. We have learned so much from you. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in one of 3 ways. You can send an email to help@aamds.org, or you can call the AMDSIF helpline at 800-747-2820, extension 2, or you can submit your question on our Facebook page. If you're watching online, please take a few minutes to complete this session survey. Your input is important to us and helps us plan future educational programming. This session concludes the educational programs of the conference. We hope you will join us for the support groups from 2:30 to 3:30 p.m. Central Time. On behalf of the Aplastic Anemia and MDS International Foundation, thank you so much for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the last 40 years. Thank you for spending your day with us.